Hello, thank you for the opportunity to share some perspectives on additional roles of enteral nutritional therapy, particularly in the perioperative period and in individuals with more complicated Crohn's disease. Whilst EEN has been well established for the role of inducing remission in active Crohn's disease, the roles in the perioperative period and in those with penetrating or stricturing Crohn's disease are less clear. I'm just going to summarize, first of all, exclusive enteral nutrition overall. And this relates back a number of decades, but in the mid-80s to this randomized controlled trial from Ireland showing a clear benefit for an elemental approach to induce remission, which in this setting was similar to response rates similar to those treated with steroids. Subsequently, polymeric formulas, as illustrated on this slide, are shown to be just as effective and have enhanced taste characteristics compared to elemental or semi-elemental formulas. Over time, generally it's accepted that primary nutritional therapy, EEN, exclusive enteral nutrition, provides equivalent responses to steroids in children with induction of remission in at least 80% of those that are just diagnosed, and a lower rate in those with more established disease. Furthermore, there's many reports showing high rates of mucosal healing. This has led to exclusive enteral nutrition being recommended as the first-line therapy in many international guidelines. Here is a section from the ECHO-ESPGHAN guideline. Similarly, the Canadian Association of Gastroenterology guideline for children, and in New Zealand, EEN again, the preferred initial therapy for those individuals that are just diagnosed with Crohn's disease. And this also translates to high use of EEN. This is a European study showing the preferred treatment at diagnosis, significantly favouring EEN. And in Australasia, a recent report suggested that almost all Australian gastroenterologists would use EEN, particularly for newly diagnosed Crohn's disease, but also many for recurrent Crohn's disease, as illustrated in this bar graph. Standard formula in our hands, so polymeric formula for up to 8 weeks, exclusive administration of formula, working out the initial required volume based on energy requirements, with regular review and multidisciplinary support over the period of treatment. So, ample evidence suggesting that exclusive enteral nutrition has a role in inducing remission, particularly in children with active Crohn's disease, and associated with high rates of mucosal healing, nutritional improvements, with many benefits as not demonstrated in detail here, but avoidance of steroids, enhanced bone health, and so on. But in the perioperative period, would this treatment help to avoid the need for surgery, improve nutrition, enhance post-surgical outcomes, and maybe even prevent recurrence? Let's review the evidence. So some of the early reports in the 70s and 80s involving small case reports and case series did show a benefit of nutritional intervention at that time. This is just one of these. A small number of individuals with Crohn's disease and ulcerative colitis. 26 were treated with EEN compared to 17 that had a normal diet. EEN in these individuals was tolerated and feasible and led to less need for surgical intervention. A number of other small reports at that point demonstrating benefits of nutritional enhancement. More recently, there's been a series of reports, some retrospective and some controlled, and we'll just look at these. This report of 50 individuals having an ileocecal resection for penetrating Crohn's disease over a 10-year period, and they had a preoperative nutritional optimization phase. In general, those that had nutritional support had low rates of complications. This was not a comparative study, however. A large number of individuals in this report, almost 500, having more than 700 procedures, 4 different groups, 2 of those as illustrated, where they received, one of those groups having exclusive enteral nutrition. And that group had lower rates of stoma requirement post-operatively, less post-operative complications altogether, and also needed less urgency in terms of their procedure. This report compared more than 50 individuals that were treated with exclusive enteral nutrition compared to 150 that did not. 13 of those that had EN no longer required their operation. Those that had EN had a lower CRP and a shorter operative time. In addition, those that went directly to surgery without nutritional support preoperatively had a 9-fold increase in post-operative leak or septic complications such as abscess. Modulin was used in this report. So 35 individuals had preoperative EEN. It was feasible in all but one of those individuals. A number on steroids were able to cease steroids. In this report, they did not demonstrate a benefit in terms of post-operative complications, but it was not controlled completely. In a report looking at individuals that had an enterocutaneous fistula, 45 were treated with 3 months of EEN, and these individuals had improved albumin and CRP. Following their procedure, intraoperative sepsis was substantially reduced in those that had had nutritional support. Prior to laparoscopic surgery, 45 individuals were treated with EEN for at least 4 weeks and compared to a group that did not have EEN. EEN led to improved nutritional and inflammatory markers, less post-operative complications, less endoscopic recurrence at 6 months, but did not alter rates of clinical recurrence at 12 months following their surgery. In a similar observation by a different series of authors, this was a prospective database, not controlled. EEN was given for at least a month in 42 individuals, and this led to improved nutritional and inflammatory markers again, and similar to the other report just mentioned, less post-operative complications, less endoscopic recurrence, but again, no difference in clinical recurrence at 12 months post-operatively. Another report more last year from Portugal, small number of individuals. Of the 15 people that were referred, 10 received EEN, and similar story, less disease activity, less CRP, and improved albumin. And 2 of those 10 individuals did not need their operation after a period of nutritional support. And just to illustrate, this is not unique to adults with Crohn's disease. This is a report from Scotland focusing on prehabilitation. And it was retrospective, a small number of individuals, 8 who received preoperative exclusive enteral nutrition compared to 9 who did not. And they showed that post the histological assessment of the resected specimen, there was less moderate to severe inflammation in those that had received preoperative nutrition. There was a suggestion of other advantages, but these were not significantly different in terms of post-operative complications, for instance. However, this was a very small number of children that were treated in this fashion. So in summary, it does seem that preoperative nutrition leads to reduced inflammation, reduced post-operative complications such as sepsis, and reduced post-operative leak or abscess, whilst also improving nutritional status in various ways. And this is summarized further in an ECHO review published last year. They had a number of practice positions, and this is just one of those that EEN has promised as a preoperative optimization strategy for reducing complications and improving nutritional status in patients with Crohn's disease. How about after that operation? Does EEN have a role in this period? And there's some Japanese data looking at this in particular. So in these individuals that had an ileal or ileocolonic resection, 20 of them had control diet and 20 of them had overnight enteral nutrition with a low-fat diet during the day. And they were followed for 5 years and looked at the need for infliximab or the need for reoperation. And these two graphs illustrate this in terms of on the left, we have those that needed infliximab, showing a significant reduction in the control in the EEN group in terms of those needing infliximab for up to 5 years afterwards. And although there was some separation in those needing reoperation, it was not statistically different. A different report, 40 individuals who after their resection were given either less than 1,200 calories overnight or greater than 1,200 calories overnight. And those with the higher volume of enteral nutrition overnight had a reduced recurrence rate, especially in those that had had penetrating Crohn's. Moving on to thinking about complicated Crohn's disease with a stricture or with penetration. There's some case series and small case report data looking at exclusive enteral nutrition in instances such as enterovesical Crohn's disease, a perianal fistula, enteroenteric or enterocutaneous, and in those with enteroenteric Crohn's disease with a phlegmon, generally showing substantial rates of benefits with either closure of the fistula or resolution of the phlegmon or abscess. Just to illustrate this further, this was 2 reports, so 50 individuals with stricturing Crohn's disease that were treated with exclusive enteral nutrition. Almost all of those had clinical remission and 70% had radiological remission. A second very small report, 7 individuals with stricturing Crohn's disease, 4 of those entered remission with EEN and were maintained on remission for up to 2 years with further nutritional support. So in conclusion, EEN has a clear role in the induction of remission of active Crohn's disease, especially in children. But there's certainly developing data demonstrating that EEN has roles in the perioperative period, with some of the signals being that some individuals will be able to avoid their surgery or at least delay their operation. But perhaps equally importantly, less post-surgical complications and less recurrence afterwards. In addition, there's support from small case reports and case series, uncontrolled, of the role of EEN in complicated Crohn's disease with stricture or fistula development. I'd like to thank you for your attention and conclude at this point. Thank you.